to the Alamo Advocate Program. My name is Lisa Bethune. I am an Alamo Scholar. This year, we are dedicating our program to Laura Bowers, and I am also honored to present our moment of silence. Anne McGuire. Anne McGuire spent her life advocating for social justice issues, including homelessness, women's health, and access to care. After being diagnosed with breast cancer in 1989, she moved to action, becoming a strong advocate for breast cancer. She was a founding board member of NBCC, representing the Women's Community Cancer Project on our board, and served for a time as NBCC's vice president, and also helped organize the Massachusetts Breast Cancer Coalition, serving as their first president. In the early 1990s, Anne spearheaded efforts in Massachusetts to become the first state to declare breast cancer an epidemic. She then turned on to secure state funding to establish the Silent Spring Institute, the first research organization investigating the link between breast cancer and the environment. Anne was not only a breast cancer advocate, but an advocate for LGBT rights and people experiencing homelessness. She served on the board of Fenway Health, was co-chair to the Massachusetts Lesbian and Gay Political Caucus, and was a founding member of the Boston Lesbian and Gay Political Alliance. She volunteered for shelters and food pantries and served on the board of Helping Our Women, or HOW, assisting women on Cape Cod with chronic and debilitating health conditions. In addition to receiving HOW's Lifetime Achievement Award, their health center building is named in her honor. The 2016 documentary, Anne McGuire, An American Hero, honors her legacy. Anne passed away on December 29th, 2023. Please join me in a moment of silence to remember Anne. Thank you.
Good afternoon. My name is Mary Jimenez, and I get the honor and privilege to introduce our moderator for today's session. Dr. Trevino Jones is Associate Professor at the Division of Hematology Oncology at the University of Texas Health Science Center and home of the UT Mays MD Anderson Cancer Center. She's a medical oncologist that has a strategic focus in helping those patients with precision medicine tools. Look forward to hearing more about what the Cancer Center has built up, and we're fortunate to have gotten her from McGovern Medical School. Please welcome Dr. Jones.
Thank you, Mary, for that kind introduction. Good morning, everyone. Is it still morning? My name is Dr. Jessica Trevino Jones, and I'm actually a native from San Antonio. I was born here. I'm a first-generation college student and very happy to be back now as a first-generation doctor and the director of our Mays Cancer Center first ever Cancer Risk Reduction and Education Clinic, or CARE. What Mays Cancer Center and UT Health are committed to is not just moving the needle on breast cancer as we know it, but curing cancer if we prevent it from starting to begin with. So on that note, I'm pleased and thankful that the Alamo Breast Cancer Foundation invited me to give a little bit of a background on precision medicine. And today our focus is going to be on next generation sequencing, or how we're looking at tumors. So today, everybody, we're getting a 2-minute crash course in genetics. And we're gonna do that by building a recipe together. So the best way that I can describe what genetics and what precision is I want you to think about a family recipe book. Every one of you are born with a recipe book. This recipe book, your cookbook, is DNA. Your recipe book contains all the instructions needed to make the human body. Now, whether that's a muscle or a skin cell or a heart, you have a chapter just for that. And that chapter is a chromosome. And each page is a gene. You don't need to carry your recipe book around, especially when we're going over to Christmas and we're going to that company party. We don't want them to take our whole recipe book. We bring a copy. So we'll bring a copy of our recipe or our RNA. Sometimes there's going to be mistakes in the recipe book. And whether you're missing a whole chapter or whether it's just an error on the page, sometimes those mistakes can lead to a damage in a cell, and that may become cancer. Because of that, we now understand that cancer has its own recipe book. Cancer has chapters, and cancer has pages. And doing so, we're able to distinguish what is your recipe book and what is a tumor's recipe book. Everybody has 23 pairs of these chapters, and just so everybody knows, if you have three copies of chapter 21, that's actually Down syndrome. But we're going to continue just so you guys know. But in any case, we're able to try to find where these changes occur. And this is leading to precision medicine. So if you have, and I have to come down because I want to make sure I say it right. If you have an error in chapter 13, page 12, we're talking about BRCA2. And if you have an error in chapter 17, page 185, think about BRCA1. And so in doing so, whenever we think about how we can be better, not only at treating cancer, but preventing cancer altogether, we're able, if we can, try to find women early before cancer starts. And if we know there's an error on a page, maybe I can't change that recipe book right now, but what I can do is prevent that error, and we can offer different tools and strategies to prevent cancer. And how we're treating cancer is different. And so by looking at the book, by looking at the tumor, by looking at the copies, I am pleased to say that Alamo Breast Cancer Foundation has invited 3 different platforms, which we will be hearing from shortly, because of our advocacy and commitment to precision and moving the needle for breast cancer. And so with that, I would like to thank you guys for your time and invite Dr. Ezra Cohen to discuss the platform Tempest.
Thanks, Jessica, and thanks, Mary, for the invitation, and to the Alamo Group for allowing us some time to present and participation in this panel. I love that analogy, Jessica, of the recipe book, because it really flows so nicely into what I'm about to say, and some of the philosophies and missions that you're going to hear about in the next hour or so. I have control of the slides, I believe. Great. Okay. So this slide really, to me, summarizes what Tempest is all about. And some of you may have heard of Tempest. Some of you may have even had one of your tissues tested by Tempest. But the whole idea from the beginning was to collect multi-platform data, put it together, be that NGS or next generation sequencing, part of the recipe that Jessica just talked about, or your scans such as CT scans or PET scans, the clinical notes in your that your physician takes, the medications that you're on, the diagnoses, and of course the laboratory tests. Take all of that data, put it together, use computer modeling, so machine learning and AI, to begin to interrogate those data and come up with insights. And those insights take the form of therapy selection, the best treatment for that patient at that time, clinical trial matching, so are there studies that the patient would be eligible for that could further benefit their situation, and of course, treatment optimization in general. Not just therapy, but how do we manage the patient as a whole, their diet, their nutrition, their day-to-day activities. All of these recommendations can come from the data set that we assembled. And so what's useful to know for a cancer patient today? You can think of it in many ways, and here are just 4. What's going on with the tumor now? This is the recipe or the recipe book that Jessica talked about. What are the alterations in that cancer that are driving it, and perhaps how can we target them? What about the tumor over time? Of course, we know that inherent in the cancer, in cancer is the ability to mutate and to evolve over time. Well, now we have the tools to begin to measure that. What about inherent factors? And this is germline. This is that playbook, that recipe book that we're all born with. And unfortunately, we now recognize that many of us, arguably all of us, have genes in our, quote, normal DNA that may predispose us to different diseases, including cancer. And then lastly, what about clinical trials? And I'll come back to clinical trials at the end of my talk. Now, what about breast cancer specifically? Tempus, of course, is not just a breast cancer company. We look at all of oncology, and in fact, we go beyond oncology in other realms of medicine as well. But let's focus on breast cancer for obvious reasons in this talk. There's different tools that we can apply to the breast cancer patient, such as minimal residual disease and treatment monitoring. So we have a blood test that can tell a provider if that patient is at high risk for their cancer to come back, and you'll hear more about that in just a few minutes from one of my colleagues. There are also tools that can tell you if the treatment is working early on, even within the first few weeks after starting therapy. There are tools that can help your provider select the best treatment for you at this specific time, given what's going on with the disease. We talked about hereditary testing, and in fact, what we now know is that about 10% of breast cancer patients will have an incidental germline variant that predisposes them to breast cancer. And when I say incidental, these are patients who don't have the typical history that would prompt your provider or your primary care physician to order a genetic test. These are just found by chance. And then, of course, tailored testing, such as HER2 and other types of tests that may apply to you as a patient or to the patient. And we can optimize the patient care through different molecular testing strategies. I talked about minimal residual disease and disease monitoring. The tumor normal match is where that 10% number that I just told you about comes from. Because we take a normal specimen as part of our next generation sequencing, what we have found is that, again, 10%, so that's 1 out of 10 breast cancer patients, will have a germline variant, so in their, quote, normal DNA, that nobody knew about. And of course, that has implications not only on that patient's therapy, but to their relatives and their children as well. The ability to do both DNA and RNA comes into play because what we find out is that 30% of the mutations or alterations that are actionable by an FDA-approved drug are only found when you do both the DNA and the RNA. The dual testing of both tissue and blood is incredibly relevant to breast cancer because 20% of alterations in breast cancer patients are only found in the blood. And that's primarily ESR1, which I think we'll probably talk about in the session. And then there's, of course, the idea of longitudinal testing, where up to 40% of patients with a hormone-positive, HER2-negative metastatic breast cancer will develop these ESR1 mutations that I just mentioned. And then I'll leave you with the idea of clinical trials and two main drivers of this. First, the only way we are going to make progress in cancer, the only way we're going to approve tests, the only way we're going to approve therapies is through clinical trials. Sadly, only 3 to 7% of adult cancer patients participate in clinical trials. So we created this TIME network to help enhance clinical trial accrual. It's a network that spans the country. You see the sites there. We can activate studies, believe it or not, within 10 days. And so when a patient walks into their oncologist's office, if their oncologist is part of this network and that patient qualifies for a trial in the network, they can get enrolled on that study. And then the other thing to keep in mind for clinical trials is that there are now solid data repetitively that patients on clinical trials do better, even when they are matched for their other health considerations, their age, their performance status. A patient on a clinical trial does better than a patient treated on standard of care. Another reason to think about clinical trials. So what Tempus has tried to do is provide a comprehensive solution for patients throughout their cancer journey. And I'll thank you again for your attention. Thank you for allowing me to participate, and I'm very excited for the panel discussion. Thanks, Jessica.
Thank you, Ezra. Up next, we have Dr. Angel Rodriguez, ready to talk to us about Natera.
Thank you, Dr. Jones, and thank you to the Alamo Breast Cancer Foundation for inviting us and allowing us to talk about this very important subject. I'm Angel Rodriguez, breast medical oncologist and medical director at Natera, and I'll be talking to you today about a test that looks for DNA in the blood, right? Natera is basically a company that specializes in detecting and evaluating fragments of DNA in the blood. And this can be used for many different reasons. Initially, the first offering for Natera was a test for pregnant women, a non-invasive prenatal test, which basically looks and detects the fragments of DNA of fetuses in the pregnant person's blood, so that we can evaluate early if there are any serious genetic anomalies in the baby. And then in transplant health, we use also these DNA that spills into the blood from a patient who's had let's say, a kidney transplant, to detect those fragments of DNA from that donated kidney in the blood, and are able to then predict, based on those levels, if a patient is destined to have a transplant rejection, so that we can avoid the rejection by giving immunosuppressants. And so that technology was applied in cancer. So one of the ways that I like to think about this is that cancer has a lot of weaknesses. And here we exploit another of its weaknesses, and that is that as cancer cells are formed and grow and divide, they spill some of its contents into the blood. And fragments of DNA that are unique to that cancer can be sort of detected. And ultimately, I'll show you how this can be used in breast cancer. So that test is called Signatera, a test that was purposefully built to detect residual disease at the molecular level in the blood. Altera is a test that basically, as you are examining or sequencing, understanding what the tumor genetic profile is, can report out, well, what were the anomalies that were detected. And then Empower, as you all know, is a hereditary cancer test, right? So understanding not just the tumor, but also your own blood, your own DNA. So this illustrates how that weakness of the cancer cells that I described, right? So cancer cells release this DNA into the blood, and we call that circulating tumor DNA, ctDNA for short. And this allows us to then interrogate what these sort of DNA fragments will look like, what do they have. And one way this is used today in 2024 is to determine whether a particular mutation is present, so that a particular treatment can be given based on that mutation. Now, a more novel way of the test is to use it just to detect if there is disease present, yes or no, as opposed to looking exactly what is the mutation that is found. And because DNA these circulating tumor DNA fragments are so quickly processed by the blood within hours, it turns out to be a decent biomarker that can tell, like, in real time whether the tumor is present. Now, So very simply, the way that this test is done is a patient a blood sample to interrogate, as Dr. Jones mentioned, the cookbook of the patient, make sure there's no proofreading, everything is right. And then on the other hand, when the tumor, when cancer forms, it forms because mutations arise. And so now you can compare the two and then find out, well, what is unique to each and every patient's tumor sample? What is unique to that patient's tumor that we can then turn into a blood test, patient-specific blood test, to monitor for these changes in the blood. And so as you see on number 3, it can then become a test that, from the time of diagnosis, as patients are getting treatment and surgery, we want to see those levels go down to undetectable levels. So very simply, what does it mean when having a blood test, whether it's negative or positive? Well, the first bullet point on the left, right, when somebody has an early stage cancer and a test is negative, it means, well, at that time, DNA from the tumor was not detected. Now, one common question that we get is, does that mean that the patient is cured? Unfortunately, no. There are some limitations to biology of cancer that allows for cancers to sometimes be dormant, be sleeping, and not shed ctDNA into the blood and not detected when it's actually there. So when a result is not detected, it certainly means that the risk of recurrence is very, very low, especially for the next 3-6 months, but not necessarily for the rest of the lifetime. And in breast cancer, unfortunately, recurrences can happen very, very late. A single test is not enough to determine that. Now, if a result is positive, it basically means that a DNA from the tumor that was analyzed was detected in the blood. And it may mean that that disease is already there and that when doing a scan, you might find it, and whether it's found locally on the breast, on an axilla, or disseminated in other parts of the body can only be determined once the scan is done. But on occasions, the scan will not show the disease yet. And the question is there anything that we can do at that moment in time to then eradicate that DNA, eradicate whatever micrometastatic disease might be there? And I'll talk a little bit about that. So then, how can one then potentially use this technology? Well, if you look at starting from patient journey at diagnosis, can I safely reduce chemotherapy that I am getting upfront in 2024? That is not something that should be done with this technology, right? Today, everybody should be receiving the best standard of care treatment approaches. But there are ongoing trials to determine whether we can give less treatment safely to patients that are undergoing treatment. And a lot of exciting data was presented in this year's San Antonio Symposium. Now, other questions are, will patient benefit from the additional treatment or any chemotherapy? So this is something that, again, in 2024, this test should not inform somebody to, I'm not going to do treatment because it's negative. No, not yet. These studies are happening prospectively. Now, in the setting where sometimes decisions can be complicated and complex, and there's multiple options that can be considered, a positive result means that the risk of recurrence is high, and that may inform decision to do more intense treatment. And these are basically some of the ongoing trials that at the end of the day are trying to answer the question, if we detect DNA in the blood prior to metastatic recurrence, can we eradicate it by intervening earlier with treatment? And so these are just some examples of some of those studies where intervention is changed based on the result. And with that, I would strongly encourage that, seeking information and also It's going to be very crucial to enroll patients in clinical trials to ultimately prove the point that if we intervene earlier with this result, that outcomes can improve. Was it? Thank you.
Thank you, Angel. Next, we have Erick Anderson with Exact Science.
Thank you, and thank you to Mary and the foundation for giving me the chance to speak to you today. My name is Erick Anderson. I'm a genetic counselor and a senior medical science liaison for Exact Sciences. So just a quick disclosure, of course, I'm an employee of Exact Sciences, and nothing should be interpreted here today as medical advice, and you should seek the expertise of your treating physician. So I wanted to talk to you just briefly about Exact Sciences and our mission, which is really to eradicate cancer and the suffering that it causes. And we've gone about trying to approach that challenge by creating an array of tests that can be utilized by both patients and clinicians alike to understand risk of cancer before, during, and after diagnosis. So on the left side of the slide here, you see, as we've talked about, a test called RiskGuard, which is our hereditary cancer test. I would like to highlight that that is a test that can be ordered in multiple settings, whether it be a primary care physician, an OBGYN. It doesn't only need to be ordered by a medical oncologist or a breast surgeon. And the reason why I feel that is important as a genetic counselor is that a lot of the benefit that we get from knowing your hereditary risk is understanding how we should surveil you. If you should start mammography early, MRI, stuff like that. We also have a test called Cologuard, which is for colorectal cancer screening. You might recognize it from the dancing white boxes that you see on the commercials during the football game, something like that, but a non-invasive, stool-based, multi-targeted DNA test that is for individuals that are 45 years of age or older that are average risk of colorectal cancer, and a really important screening test. It does over 1 million samples are processed in the lab every single quarter. So just pretty amazing scale. The lab is as big as a football field. It's really a sight to behold. And then we have our Oncotype DX suite of assays. I'm sure many of you in the room are aware of Oncotype DX. Maybe you have had an Oncotype DX assay yourself. But really, its purpose is to provide information around prognosis as well as treatment guidance. So when you get an Oncotype result, you get a distant recurrence risk as well as an estimated chemotherapy benefit. And I will kind of get into the data a little bit further around Oncotype later in the presentation. We also have a molecular residual disease test that is in development. Data will be shared in 2025 on that test. And then we have a therapy selection test called OncoExtra, which again is there to identify those actionable variants that might be utilized by your clinician to assign you a certain therapy. So just to kind of level set a little bit here, we talked a little bit about the cookbook, hereditary cancer testing. We also do biomarker testing in Exact Sciences. And the way I would kind of differentiate genetics and genomics is, genomics is typically looking at your tumor. That could be either expression of genes or looking for variants in that tumor to target. It is not heritable, where hereditary testing is heritable, and it can be found in all cells. So if we took saliva cells or blood cells, we could identify those variants there. So I'm here a little bit to talk about Oncotype today, and we have tested 1.8 million patients with Oncotype, pretty amazing feat. And I kind of wanted to go back to the beginning and just show you 2 slides on some of the data that we had utilized to really show that we can predict chemotherapy benefit. So this was our initial validation study called B20. It was published in 2006, looking at patients that were assigned to tamoxifen or alone or chemotherapy plus tamoxifen. And you can see by the black curves, this is the overall population. There was a slight benefit in the overall population to being assigned chemotherapy. But when we looked at recurrence score, we found that if you had a low recurrence score, at this time the cut points were less than 18, and you were assigned chemotherapy or chemotherapy plus tamoxifen, you did not benefit from chemotherapy. We also saw that in the green lines when we were looking at recurrence scores 18 to 30, and we saw most of the benefit was really occurring in the women that had recurrence scores of 31 and above. So we saw a 28% absolute benefit of chemotherapy in that group. So of course, we needed to prove this with a prospective trial, really the gold standard for randomized for level of evidence. And we did that with a trial called Taylor-X. You may have heard of it. It reported in 2008 by Dr. Joe Sperano and his peers. And this was a randomized trial looking at women that were node negative with recurrence scores 11 to 25. And what you're really looking at here is there's really two curves that are sitting on top of each other. These women were randomized to endocrine therapy alone or chemotherapy followed by endocrine therapy. And this is exactly the result that the investigators were hoping to see. So you can see at 9 years for invasive disease-free survival, and on the right side, looking at distant recurrence-free interval, there was no benefit to chemotherapy. So this was really a practice-changing result. It helped inform the guidelines, as well as kind of our future directions in the node-positive disease trials as well. Thank you so much.
Thank you, Eric. Okay, well, thank you to all of our speakers, and I think that was wonderful. We're opening now to any questions that you may have. Please come to the microphone, and do know, I'm sure everyone's about to get a Amber Alert, so if we have a moment for our Amber Alert. Also, I hope that we're able to capture your attention. If not, do remember we have digital booths that you can please visit while we are going through these questions. Please, microphone 1.
Hi, I'm Christine Carpenter from the Beyond Pink team in the National Breast Cancer Coalition. Mm-hmm. And I have a question for the 1 and 3 speakers. So those of us, which are many back home too, who've had a breast cancer, and we're really worried about our adult daughters also getting breast cancer. But we know we don't have the BRCA genes, that sort of thing. Should we be having our adult daughters get your test so that they don't have to have such active surveillance?
Excellent question. Eric, do you want to?
Sure, that is a great question. One of the things that I'd like to highlight is that your own advocacy is going to be really important in obtaining a test for a family member like that. So there are different societies that different clinicians follow. So oncologists will follow their guidelines by their society for germline testing. Primary care might follow a different guideline. And that's an important question that you can ask your clinician when you're trying to advocate for a germline test. But what I would say is that if you are encountering some resistance there, I believe there are still options that are semi-affordable if you wanted to do any kind of cash pay price. The cost of sequencing has gone down dramatically over the last 10 years, and that has allowed labs to offer germline testing at really affordable prices. But I would say that you should advocate with your healthcare providers to get that, because there are some societies like the American Society of Breast Surgeons that advocate, for any woman that had breast cancer to get germline testing, and then the societal guidelines have gotten more liberal for family testing as well.
And I think,
yeah, if I could make a comment on that, very good, nice question. I'd say a few things. First, inherent in your question is what you're alluding to is that your daughter, because you had breast cancer, has an increased risk of having breast cancer. Mm-hmm, right. We don't fully understand that risk. There's certainly a genetic component to it, and the reality is in 2024, we don't understand the whole genomics of hereditary breast cancer. Mm-hmm. Having said that, the question I would ask you or ask your provider is how comprehensive a genomic profile did you get? Because we're now beginning to understand that it's way beyond BRCA. BRCA 1 and 2 make up a small percentage of patients who are at her. I hope they found her. A small percentage of patients who are at risk, but there are multiple other genes that also predispose to breast cancer, and I would advocate that you get, if you haven't already, a fairly wide panel of genes, of screening that encompasses now almost 150 different genes that can predispose to hereditary cancer syndromes. And then the last thing I would say is that many of the companies, including the ones represented here, have financial assistance programs. And so even if your insurance doesn't cover it, the tests are often covered, and I would say the great majority of the time are covered by these financial assistance programs. And so you likely will not have to bear that burden. But last thing, sorry, if your cancer screen comes up negative, a comprehensive screen, then I don't see a reason why your daughter should be tested.
Right, yeah.
answer.
So, okay, now I'm talking about my own case, which I'm not supposed to do. But I did have I don't know, probably 5 years ago, I had the most comprehensive screening at that time. I had none of the markers.
That's great.
So does she still need all this, all these MRIs and all this?
Well, if I can
that's
take
the
this
part.
question. I'll go ahead and answer this question for you, and I know we're on a tight schedule, but we do know that there is a genetic component, but we don't have all the answers yet, and that's another emphasis for clinical trials. And even with that being said, I would encourage your daughter to go to her primary care doctor for a risk assessment, because even outside of genes, those services. So the risk and benefit of continuing enhanced screening with those MRIs, that's something that is a very individualized conversation based on age as well. Thank you for your question.
Can I ask? I'll come back.
Thank you. This microphone, please.
Sherry Merritt, Alamo Scholar and Susan Komen Science Advocate. On Signatura, I know it's tumor-based. So what about the fact that some cancers can actually migrate and turn into something else? So how does it deal with that? Like if you start out with, say, HER2 and ended up hormone negative or whatever?
Very good question and very common question that we get. And I'd like to answer that with some really cool data that was presented at the European Medical Oncology Conference, where we actually looked at mutations that happen over time on patients on treatment, and imagine basically looking at the mutational profile at the beginning of treatment, then in the middle of treatment, and then at the end. And so we basically compared what happens to the mutations of cancer and exactly what you just said, that the conservation of mutations goes to like 30%, meaning that yes, many mutations are lost, many are gained. But interestingly, the way these tests are designed, they are designed in such a way that the mutations that are identified and tracked are the most, we call them clonal, meaning that these are mutations that are unique and will be found in every cancer cell, even when it expands and changes over time. So what we saw was that the mutations that were selected for the assay, those were still present at every time, even after treatment. And so you can, even though we use we can use the initial biopsy, it is still good enough to use to monitor even in metastatic setting.
But you can't do it without a biopsy period. You have to have a biopsy.
At the beginning of a diagnosis, yes, to design the first test, yes.
And then the other thing is, all different cancers should have gene testing. Like for example, I'm HER2 and they didn't do any gene testing. And I knew they do BRCA, but I didn't fit in that category. So like, HER2 and triple negative should get it as well?
The genetic testing, hereditary testing now?
The hereditary.
Yeah, I mean, I think that most importantly is, I'd like to give a plug to the high-risk clinics, right? All of our sort of, there's a lot of high-risk clinics out there that there's so many nuances to a particular sort of a case that can allow you to really inform you the best, all the pros and cons of getting tested. Generally speaking, however, I personally speaking, I think that genetic testing should be for all, but that's not necessarily.
On that note,
I completely agree.
Thank you for the question.
Yeah, because I was just curious, genetic, not in any particular case, but overall, if we have patients with different types, should we always say, ask your doctor about the possibility of doing that?
For sure.
Thank you very much. I want to make sure we take at least 2 more questions before we move on to some case examples. So for our next 2 attendees, if I can have this lovely woman and this one too, and if you have, for the other individuals, please know you're welcome to come up to the stage after our presentation to ask us questions directly. What is your question?
Thank you. Hi, I'm Panita Khan, and I'm a patient advocate. So I use the Oncotype DX for during my treatment plan, and my question is the TAILOR-X study. Have there been any follow-up studies on the accuracy of the predictability? Because I did choose to avoid chemotherapy, but and that was 8 years ago. So there's always the concern, well, was it really a good decision back then, or the recurrence rate?
Yeah, well, that, of course, would be dependent on the score that you received. But
6.
All right, well, there you go. That's a very great score. Of course, you want a lower score. I think in general, you should feel very confident in the TAILOR-X results. That was one of the largest adjuvant breast cancer trials that was run. There was 10,273 patients that were enrolled in it. The randomized arm had 6,700 patients, 3,300 in each arm, the chemotherapy arm and the endocrine therapy alone arm. And so I think you can feel very confident that that level of evidence will provided a result that you can be confident in.
Great question.
Hi, I'm Megan O'Neill. I'm an Alamo advocate and Tempest user, so thank you. I'm working with Living Beyond Breast Cancer on a campaign to spread the awareness of the importance for metastatic breast cancer patients to get genomic testing, not only at the time of diagnosis, but anytime they progress. The campaign is called No One Missed, because I feel like so many people are missing this. Why is that? If insurance is covering it, why are we requiring patients to be going to their doctors in order to get this test when we know how important precision medicine is?
I know.
It's a great question, and you probably could see the frustration on our faces.
Yes, thank you. I appreciate that.
And not only those 2 points that you just made, but the guidelines also support it. And these tests are, I would say, rarely not reimbursed. So your question is a good one. I think part of it is, let's say, patients' perceptions of these types of tests and their utility. There's a fear around it, for sure. Sometimes people don't want to know. So I think that's one thing. Second thing, and I think probably the most important, is that there is a knowledge gap. There's a knowledge gap among primary care physicians, and to me, most distressingly, there's a knowledge gap among oncologists. Now, oncologists, your typical community oncologist is seeing 20 to 30 patients a day of all kinds of cancers, and it's impossible to keep up. So I'm not making excuses, but that's the reality of the situation, and so they may not be up on every single guideline that is available, speaking to the patient in front of them. So there is a knowledge gap, and we and others are trying to bridge that as rapidly as possible. As advocates, you have an important role to play there, because not only are you educating patients, but you're educating providers as well. And then lastly, I think there is a bit of a utility issue. So I get my test. I get this result. Well, what do I do with it? And we're still trying to figure that out for some patients and some of the hereditary or the germline pathogenic mutations we find, or even the variants of unknown significance, or VUS, that we find. And there's some controversy in terms of what the next steps should be. So in my opinion, I think those are the main factors that drive this gap between what should be done and what is actually being done.
Mm-hmm. Very, very good. Do you have any extra comments to this as well?
No, I think we're done with so yeah.
I guess my question then to the audience is, has anybody in the audience had something like a variant of unknown significance come up? And second question, right, is how many of you have had pushback or had challenges with getting testing covered? I would like to see a show of hands to know that. It's just shocking to see so many hands coming up. And so excellent question. Thank you.
Thank you.
Of course. Oh my goodness. Of course. Let's please.
In the U.S., I had no trouble getting tested. So
Great.
yeah. And but also, then a year or two later, they discovered that it was not significant.
Well, if I may take the online question first, just because I am now trying to understand our new technology, right? Even we all are learning. Our online question is, it isn't clear how to interpret Signatera numbers, and I couldn't find anything on the website on how to interpret the numbers. If the Signatera test goes from 1.25 to 3, let's say, in 9 months, how is that rise interpreted? And how are we using numbers like greater than 10 or greater than 20?
Great. So it's a good question. I think like everything we do in oncology, a diagnostic test should not be interpreted in isolation, right? Just looking at it without knowing what else is happening. Certainly, in the setting of, and this is like 9 months, which is pretty far apart, but in the setting where their treatment has not changed and levels are going up, it could be interpreted as suggestion that the tumor burden at the molecular level is rising. So in scenarios where there is questionable doubt as to whether the disease is progressing or not, this is just another aid to the information that the disease might be progressing. But in the scenario, let's say that a scan shows everything is stable and the patient is clearly healthy and there's no question of disease, in 2024 today, a change in treatment based on that rise should not be done. And we should continue to stick to our instincts, right, of how we do normal things. So the important thing is to not interpret it in isolation.
Excellent. May I take your question? May I take your question?
I guess my name is Ren, and I'm a patient advocate. And my question is, as a metastatic breast cancer patient, I'm a little confused with like the efficacy between early stage and late stage with the Signatera, because I'm MTNBC 5 years now, and I'm on an immunotherapy that's led me to be NED for 4.5 years.
Wow.
And I had the Signatera test the first time, and it came back negative. Mm-hmm. But when I spoke to when I was first diagnosed, I was explained that the cancer with stage 4 is always circulating in the bloodstream. And so I was always very confused how I could end up with a negative. And the more advocates I spoke to, the more I heard that there are false negatives. Mm-hmm. And I guess for me, I was happy with the negative result, but at the same time concerned mm-hmm. that this isn't what I was taught that MBC is, and I don't want, mm-hmm. yeah. I want the reality. I want to be a realist in this situation, but also mm-hmm. with being NED for 4.5 years, is there a possibility that there is no cancer in the bloodstream, being an MBC patient?
Yeah, I think to simplify the question, what does a negative result mean in the setting of metastatic disease? Mm-hmm. Well, number one is that the treatment that we're on, we can say that it's not resistant, that the treatment that we're on is effective, right, at sort of maintaining it at 0. Now, the other part of it, what it could mean, which actually studies are being done now, is if treatment is stopped, will that 0 remain 0 and no disease will come in the future? A bit too early to act upon sort of just say, just because it's 0, I'm going to stop. And yeah, we need to wait for the clinical trials that are happening to say that, hey, if a patient stops treatment and you continue to monitor that, if they do pop up back to positive off of treatment, then that patient we know we should go back on. But those are honestly right now clinical trials. So a 0 should not be interpreted as disease is completely away. It could still be there. The disease could still be there.
Please.
If I could just add to that comment,
Yeah.
completely agree. So if you look at another measure of ctDNA using MRD, so different data set from a company called Personalis, reassuringly, patients who were treated with immunotherapy whose level was undetected, so went down to 0, on immunotherapy, their survival was excellent, close to 100%. Now, there are no guarantees in cancer, as you well know. I don't have to tell this audience, but those data look remarkable for patients on immunotherapy who go down to undetectable.
And that's for MTNBC? Any subtype?
It was all comers. It was an all-comer cohort treated with immunotherapy. I don't remember how many TNBC patients were in that cohort. Happy to look up those data if you want to catch me afterwards, but it was an all-comer, all cancer cohort.
Thank you for the hope.
Thank you for your question.
Okay, Christine Carpenter again, this time with the National Breast Cancer Coalition. Since I asked the question about all of us having our daughters tested, mm-hmm. Thankfully I'm a long-term survivor, but I remember working to pass the Genetic Non-Discrimination Act, and it was passed. However, NBCC did not afterwards, they did not champion it because it did not have teeth. You do not have the ability to sue. And so because I know that and have talked to genetic counselors about it, and they say, yeah, I'm right, that I do not allow my daughter to get genetically tested, since I do all the testing because I'm already a cancer patient. And I don't want her, especially with the incoming administration, it would worry me that she might lose access to health insurance, life insurance, that sort of thing, if she has that on her health record.
Regina, do you want to take that,
Yeah,
Eric?
sure.
Regina?
I would have to go over the specifics of that bill, but I think generally one of the things that we do counsel our patients on is the life insurance portion. Anytime you're going to get life insurance, they're looking for risk. And so sometimes we do advocate that if that is something that you want to pursue, that you do that prior to getting genetic testing. And especially in this scenario where it is not urgent or maybe surgical or therapy decisions aren't going to be made off that result, they have, more time to do that. So that is one thing that we do advocate for.
Thank you. And this microphone.
Hi, thank you. It's Kirsten Spence from METUP UK and Alamo Scholar. I just want to talk again about, I've got some real concerns about this genomic testing from the blood, the ctDNA testing. And that's because I'm actually seeing a lot of patients coming and saying, I don't understand, I'm getting these negative tests. Yeah, I know I've got cancer going crazy. So then they look at the tumour from the bones, this is from the bones, and yes, they've got, like 20% allele frequencies of several mutations. So we're talking substantial stuff going on in the bones, but it's silent in the blood. And I think what really starts to worry me about this is that you look at drugs like elacestrant, and this is partnered with the Guardant 360, and patients are really scared because they're coming back with, oh, you've got no problems, you've got no blood, and you can't access the treatment because you haven't had ESR1 found. Yet ESR1 is rife in their tumours in the bones. Then I looked at site-specific shedding. Mm-hmm. Now, bone isn't great at shedding into the blood, apparently. Lungs, they love to shed everywhere. They're brilliant. But bones, not so much. Now, 70% of people get metastasis to the bones. That's where the initial metastasis is. At the point elacestrant is being used, it's going to need to be found in the blood. It needs to be found earlier, basically. What's going on here? How can you help people who are going to need to access these drugs through these tests, and they're not really quite sensitive enough? Is there? I mean, and it worries me because I know people, not just Guardant 360. I'm only mentioning that because it's the partnered test. But people are coming back and they are not finding it, but it's there.
Before anyone answers, if I may rephrase the question for those of us that are a little less medical, the question, that was an excellent question.
Sorry,
the question is, our metastatic breast cancer patients, we have diseases in different parts of the body. And the technologies that we're talking about and how they detect cancer, they will be used differently. And how can we use them differently depending on which sites of the body the cancer is at? And right now, if cancer is only in the bone, it's very challenging to leverage some of the technology that we're discussing. And so that's what the question is, because it can also offer us opportunities to give new medications that have a lot of great data behind it. And so now with extra question and rephrasing, does anyone want to take a stab at that question?
I mean, I'd like to maybe reference one of the studies that was presented yesterday, a study called the EMBER-3.
Oh, yes, I know about that.
Right, so what was, really promising about that study was that we saw a benefit to a drug like elacestrant, but it was imlunestrant, and that we saw benefit in
and can
both.
I just say, lasofoxfen outperforms imlunestrant as well.
Okay.
In each setting.
and I think what I think this alludes to your question because what if the patient does not have an ESR1 mutation? Are there patients that could benefit? And I think that study showed that they could. Now, but having said that, like right now, when we do clinical trials, we do it in a certain way. And so the way the studies were done, that particular patient, unfortunately, would not have derived the benefit according to the data that came out from elacestrant, right? So if you had undetectable DNA by the test, you had undetectable DNA, and we saw that it was no benefit. Now, a unique patient might be different, right?
No, I'm talking about generally patients who only have it in the bone. So I
Sure.
know about 3 or 4 who have failed the test. But luckily, and not many people will be able to do this unless they have private health insurance, because I come from the UK. So most people in the UK will not be able to do this. But they were able to get their surgical team to go into the bone and get a bone biopsy.
Yeah.
And then all of them had high, 20%, about 20%, some had 15 of ESR1 mutation, and they would definitely benefit from the ESR1 targeted mutation targeted.
I mean, look what
so
you're
it's just
getting
something
at.
I want patients to be aware of as well. It's like a little warning that, you know, if you've got, if you don't always find it in the blood, do ask them to look at your scans. And the other thing is, they all had CA125 tests, CA15-3 tests, CA19-9, and you could see the tumour levels going up in the blood. So they had they were showing on, actually it was 15-3 was the most one that was used, and it doesn't always work for all patients, but obviously these were sensitive. So they knew there was an issue. But yes, it wasn't detected on these tests, and I'm just saying that is something we need to try and get it more sensitive. Please be aware. Thank you.
Well, there are technologies emerging to do just that, and what you pointed out is that every technology has a limitation, and as you said before, you can't look at one test in isolation. You have to look at it in the context of that patient.
Thank you.
I think also it highlights our need to let women know about clinical trials, as we were just discussing how to get medications and opportunities to women even without these mutations, as we're now studying. Thank you all for those questions. So I had a couple questions for our panel here. So I think having a patient scenario would be good if I could, because this may resonate with some of the women in our audience. Let's say we have a 50-year-old woman with a 2-centimeter breast mass, and we found out that it was hormone-positive breast cancer with an 80% ER positivity, 50% PR positivity, and HER2 1+. She was told that her treatment requires surgery up front, and her oncotype was 12. So our question to you is, and I think again here, how confident can a woman be when her doctor tells her about 12 and omitting chemotherapy, and where does the role of hormonal therapy like tamoxifen come into play for this?
Yeah, that's a great question. So, just as a reminder, oncotype is applicable for ER-positive, HER2-negative disease. There are other genomic assays that can be utilized outside of that subtype, like HER2-positive disease, triple-negative disease. But again, the reference that I would have, depending on her nodal status, let's just assume she's node negative, is that we can feel confident from the TAILORx data that woman can safely forego chemotherapy. We proved that over that 10-year trial, and there's actually was follow-up, a 12-year follow-up by Dr. Sperano that read out last year. And so the follow-up has gotten so long now that we can feel really confident in those results.
Thank you. Now the next question is, a 2-centimeter hormone-positive cancer is treated dramatically different than, let's say, a triple-negative breast cancer. And so our question for Natera, I think today we had some excellent data that was being presented, even if it's not always the positive that we would want. But if there was a patient with 2-centimeter triple-negative breast cancer and her doctor told her that she needed chemotherapy and immunotherapy up front, what value, while I know it's not standard of care, what do you have to say about commentary about ctDNA and MRD in a neoadjuvant setting?
Yeah, so very good questions, and I think this alludes to a lot of the things that we're learning right now about what ctDNA testing is telling us as you mentioned, in the molecular residual disease setting. And so collaboration with the group I-SPY2 consortium, where basically, patients basically go on clinical trials, and we look at the blood test over time retrospectively. And that basically analysis show that when patients clear their ctDNA, right, that when they're diagnosed, detecting ctDNA is at diagnosis before treatment, that after just one cycle of treatment or 3 weeks of treatment, when ctDNA goes down to 0, now we're starting to stratify patients based on risk, just looking at that blood test and seeing that the chances of recurrence for those group of patients that ctDNA goes down to 0 quickly has a better prognosis, better outcomes than others. So it's kind of like one of an added feature aid to then thinking about in the future, okay, maybe this patient population doesn't need to be treated as aggressively with treatment than others. Again, right now, just as an aid in terms of what that risk might be versus patients who didn't clear, but may still go down and didn't clear. It's the potential of identifying patients that might be at higher risk in the future, and then now we need to start thinking this is a patient population that we should think of clinical trials or monitoring and detecting disease.
Thank you so much. And if I may just add one more before I take a question at this podium. Oh, just kidding. I would love your question right now. What's your question?
So 30-year survivor, stage 3B. At the time, none of this was available, as y'all are too young to know, but none of this was available. AI wasn't available. We used the Gale model, basically, and you looked. So I was in a clinical trial, and it was determined to determine safety. And so I got the same treatment that a 6-foot, 200-pound man got. Wow. And I'm 5 feet tall. So I am amazed of how far this has come. And so when it was genomic health, so to Exact Science, and one of the things that genomic health did, and I think that Exact Science does, is you need patient advocates. You need patients to talk about your product. If you go in, you ask the doctor. If they don't mention any of the tests, you ask them, have you tried this? Can I have this? Can I have this? So I suggest that you find a patient advocate in your area and take them under your wing, explain everything thoroughly, and then have them get other patients for you for testing.
Well said. Thank you.
I don't know, do y'all save tumors anymore?
Well, we actually we send the tumor block for, a lot of times there can be additional analysis that the sending site might want to do, or they might want to use that block for research or other clinical trials as well, so we do send those back.
Thank you.
Yeah, I just wondered, because my tumor was with Ken Osborne in his FAMIA study, and he had just moved to Houston when they had their flood, and guess where all the tumors were? In the basement. So, you know.
Thank you.
Because it's important for the advocates to say, yes, you get my test, you know, you have my tumor, you have my permission to use my tumor.
Well
Absolutely.
said.
Yeah,
Equity towards health equity.
Absolutely.
Yeah, thank you.
So thank you. And I met you before. At Maze.
Thank you. So I think in our last question, if I could, and this is directed to to Ezra. Now our patient is 60 years old. Her oncotype was 12. She did not get chemotherapy, but she developed, and she remained on hormonal therapy for 10 years because it was recommended to her. She now has bone pain, and she's found to have a bone lesion, and it's biopsied as estrogen positive, HER2 negative. How do you feel that adding these molecular testing and biomarker testing can personalize treatment? And do you see well, anyway, I'll let you answer that part
Yeah,
first.
thanks, Jessica. I'll say a few things. First, I'm a practicing medical oncologist still, and so I encounter this question really on a regular basis. And what I tell patients is, cancer is a complex disease, and we don't know what we don't know. And so getting to this case that you just illustrated, if we don't do the additional sequencing, DNA, RNA, circulating tumor DNA, we don't have that window. We haven't pulled the curtain to understand as much as we can about what's going on with that person's cancer. And there may be mutations that are targetable PI3 kinase mutations, for instance. There may be mutations that pretend resistance. ESR1, one of the questioners talked about. There may be alterations that are linked very tightly with prognosis and time on therapy for the first-line treatment for a patient like this, such as a MYC amplification or cyclin D1, and there's a list of ones that would be sort of poor prognosis. So it comes down to if we don't do these tests, then we can never find out that information. And in my opinion, I think we are really doing a patient a disservice if we don't do that. Now, the counter argument is, well, a lot of times we don't find any information that can help us, and the treatment will be just the same. But that's like
Would you
an
say
ostrich.
that's specifically for estrogen positive? I think that was a question a lot of
So
women.
all the alterations that I just mentioned are specific to estrogen positive. Yeah. So everything I talked about was specific to a patient with ER positive, HER2 negative disease. But of course, it extends to HER2 positive and triple negative. And if you'll just allow me, Jessica, this is actually why Tempest was started, by the way. So many people may not know the story. It's in the public domain. Our founder, Erick Leftovsky, and now our current CEO, he started Tempest because his wife had breast cancer. And they got several opinions, and every therapy is identical, the therapeutic recommendations, and he kept asking, well, aren't you personalizing the treatment at all? And the answer was no. And that's when he said, well, this doesn't make any sense, and I'm going to start a company to personalize therapy.
A patient advocate, if you will.
Yeah.
So I've heard from a lot of women in the audience that they may ask for this, especially in the setting of estrogen positive, which is why we're using this example, and being denied or not being encouraged to, specifically because of bone. And I don't know if anyone else wants to comment on that, or what can we do as if we're a patient? What can we say? What should we be thinking?
So again, I don't want to, I can't overstress it. As a patient, I think you really need to be your own advocate and say, I want to get molecular testing. I want to get this personalized testing so that you, as my provider, can make the best decisions for me. And if that, a lot of times it just requires testing the tumor that's already banked. It doesn't even require a new biopsy, although in the setting that you're describing, I'd advocate for a biopsy, even if it's a bone biopsy, and certainly for circulating tumor DNA.
Wonderful, thank you. And so in our last 2 minutes, I'd like to invite our speakers to have maybe 1 or 2 sentences to share what their hope is for the future of precision with their respective platforms.
Yeah, well, thank you. I think one of the things that we've talked about today is that we have made incredible progress in personalized medicine. Dr. Cohen just mentioned a story about how the regimens were all the same. There's probably over 100 targeted therapies at this point, and we are making rapid developments in the technology. None of the technologies are perfect. They all have a limitation in level of detection, but I would just say that I'm more filled with hope than I ever have been in terms of our ability to utilize personalized tools to help either, identify who can maybe get off therapy, de-escalate therapy, or maybe somebody that we need to do a little bit more for. So that's my hope for personalized medicine moving forward.
Thank you.
Yeah. So looking forward, I think the future is bright to personalized medicine to avoid under and over treatment both. And obviously, clinical trial enrollment is going to be key to definitively prove that, so that we can then ultimately apply these technology broadly to everybody, not just unique scenarios. I think obviously more than 40,000 patients die of breast cancer each year, and the MRD technology is offering the opportunity to try and intercept and detect that disease recurrence at a molecular level earlier, so that we can, again, through clinical trials, hopefully see results that indeed treatment of that molecular recurrence can prevent the clinical recurrence, which leads to, unfortunately, and many times death due to breast cancer. So the future is bright, and encourage your clinicians, your sort of regional areas to seek and continue to open these clinical trials.
Yeah, for sure.
Please.
Yeah, thanks. So, I'm going to go off off topic a little bit, just a little bit, and say, especially to this audience, that you have the power, and you should use that power. And what I mean by that is that for a long time, in fact, up until current times, your provider has had the power. The health system has had the power because they've had the information. That is going to change, and in fact is changing now as we speak, because there is technology with AI applied to that technology that will allow you to have your medical records, to ask questions of those medical records in a sophisticated way, not just, hey, when was my last blood count, when was my last CT? You're going to be able to ask that AI, how do you interpret this? What should I do with this? What should I tell my provider? Are there any clinical trials that I should be going on? What tests should I have? Those apps are available right now, and they're going to become widely available. I'd encourage this audience to find those, because it's going to shift the power structure in healthcare completely to where it should be. It should be with the patients. It shouldn't be with the providers. You're the ones that have the issue. So look for those. I can tell you, just put a plug, Tempus is developing something like that, but we're not the only ones. There are many companies, and I'm really excited about those technologies because they are going to be incredibly disruptive in a good way.
Thank you very much, everyone. Now, Mary.
So thank you, everybody. I want to personally thank Genentech, Menarini Stemline, Pfizer, CMP, Daiichi Sankyo, Exact Sciences, Lilly, Merck, Novartis, GE Healthcare, Natera, Viatris, and Eisai. If you can go by their booth as well. Again, we're a cancer community, and we can do this together in numbers. We're powerful. So thank you so much for joining us this afternoon, and we hope you have safe travels back if you're going back today. And we look forward. Please come to our sessions next year. This is how we get bigger and stronger. So thank you so much.
All right, great.
And thank you to our wonderful, esteemed panelists, and Dr. Trevino Jones for stepping in and volunteering. Truly an excellent job, each and every one of you.